I'm Dr. Lisa Stevens. I head up the Pathogen Diagnostic Assurance Group at the UK Health Security Agency, and today I'm going to talk to you about the emerging threats of UK diagnostics. So, diagnostics are critical for the identification, the infection management, and containment of a pathogen, and this is particularly important. This plays a particularly important role in the frontline defence against a pathogen with pandemic potential. They aid the identification of a pathogen into a country, the identification of the first few cases, and subsequent contact tracing, and I apologise for the typo there, as well as ensuring patients receive appropriate treatments. Therefore, it's critical that our frontline diagnostics can detect pathogens of concern for effective management and containment of a pandemic threat. The UK Health Security Agency have recently published the Priority Pathogen Family Research and Development Tool, which communicates the pandemic and epidemic risk potential and the gaps in diagnostics and countermeasure tools available for those pathogens. 16 viral families were considered in the Priority Pathogen Family R&D tool, and of these 16 families, 14 families have RNA genomes. So that means that 87.5% of all viral families considered to pose a pandemic and epidemic risk within the UK Health Security Agency Priority Pathogen Family tool have an RNA genome. And RNA viruses have the highest mutation rates compared to other pathogen counterparts, as demonstrated by the graph on the left, indicated in yellow. So some examples of those RNA viruses are shown in the right-hand graph. And as you can see, coronaviruses are grouped together, indicated by stars on the graph. And I'm sure many people in this audience will understand how rapidly coronaviruses can mutate, as you saw the emergence of many variants during the COVID-19 pandemic. However, there are other RNA viruses and pathogens which have higher mutation rates than coronaviruses, and those indicated in red show other viruses such as Influenza A virus, poliovirus, and norovirus. So what's the issue with high mutation rates and diagnostics? So when mutations arise in diagnostic test target regions, it can result in target failure or a reduction in sensitivity of a diagnostic test. And we saw that play out beautifully during the COVID-19 pandemic when we had an emergence of a variant in England. And what we saw was a rapid increase in target failure in the diagnostic tests that were in use. And you can see that in the graph on the right, indicated by the orange line, which shows a rapid dropout of a particular target within that diagnostic test. And when you're talking about that in the context of a pandemic, you're talking about hundreds of thousands of tests a day that are failing. But not only that, you're talking about hundreds of thousands of tests where patients are getting a false negative test result. So this results in false negative reporting. It impacts patient safety, the management of infection, and containment of a pathogen. And this can be absolutely catastrophic in a pandemic pathogen. So what are we seeing currently? So currently we're seeing a rapid expansion of Influenza A, H5N1, which is a highly pathogenic avian influenza. And we're seeing global distribution of that virus, as shown by the map on the right-hand side. We're seeing increases in spillover events observed in atypical species. And at the moment, we've got a large spillover event in cattle being observed in the US, with clade 2.3.4.4b of H5N1, And on the left-hand side, you'll see a phylogenetic tree, and you can see how large that genetic diversity is. So we're also seeing human spillover cases in all but one of the major clades of H5N1 globally. And while we've got no human-to-human transmission yet, repeated spillover increases the risk of adaptation. And if you look at the phylogenetic tree on the left, each circle represents a human case. So if we take a deeper dive into clade 2.3.4.4b, this is the major clade that we're currently seeing globally. We're seeing increased incidence of human spillover events within H5N1 clade, this clade, and we're seeing increasing incidence of human spillover over time. So we've got time across the bottom on this phylogenetic tree. Each spot that you see towards the end of the tree indicates a human case. And in the most recent year, we're seeing many more human spillover events compared to previous years. And this includes a recent UK human spillover case that was recently identified. So my team have done a computational sequence analysis of this particular clade compared to Influenza A diagnostic test primer and probe sequences. The data we analysed came from collection dates between the 1st of January 2024 to the 30th of December 24. 4 gene targets were included in the analysis, and these were hemagglutinin, matrix protein, nuclear protein, and PB1. And we analysed between 2,069 and 2,115 sequences, and this was variable due to the sequence availability for each gene target. We screened 55 primer and probe sequences, and we compared those to H5N1 2.3.4.4b sequences, and this related to 18 diagnostic tests, both laboratory-derived tests and commercial assays where primes and probes were willingly supplied to us. 14 assays related to frontline Influenza A screening tests. So the influenza diagnostic pathway, you'll have an initial test which will confirm whether a patient has Influenza A infection. And this is followed by a secondary test which determines the subtype of that influenza. And that's important because it may have implications on the therapeutics that are chosen for that patient. So once we identified mismatches, we also assigned a risk to those mismatches, and we did that by several different criteria, which is indicated in this table, whether it was a single or multiple mismatch, the location of the mismatch within that primer, and whether a mismatch was in a probe, which poses a higher risk. We also considered the frequency of that mutation within the circulating population, and we multiplied that score, which allowed us to determine whether mismatches were low, medium, or high risk. So I'm not going to go into the nitty-gritty detail of each mutation in the primer set, but I am going to give you an overview of what we found. So of the 55 primers and probes that we analysed, 31 of those primer probes had some sort of mismatch, and 22 of those were indicated as high-risk mismatches, meaning that there was a higher risk of that diagnostic test to fail or have reduced sensitivity. 12 of those were frontline Influenza A screening tests, and 4 of those were, so all 4 that we evaluated for the subtyping indicated high-risk mismatches. So with this information, we knew that we had to do a laboratory evaluation of diagnostic tests in use across the UK, and this included screening tests that were in use in UK HSA laboratories, but also the devolved administrations. So this slide shows the outcome of that. So we obtained a H5N1 clade 2.3.4b isolate from the US, which was supplied to us by USDA. And we used that to compare to H1N1, which is a seasonal influenza, and determine the limit of detection of both. And what we found, out of 13 tests evaluated, 5 tests had comparable sensitivity to seasonal H1N1 influenza, which means the test performed at the sensitivity that we would expect. However, 8 tests demonstrated a 1 to 3 log decrease in sensitivity at the limit of detection. And this allowed us to think about the risk mitigations that we would like to implement to ensure that if H5N1 were to arrive on our shores, how we would manage those samples within the testing network. We also looked at Influenza A subtyping assays. One assay, which was designed to detect H1, was found to cross-react with H5N1, which would result in a misdiagnosis. And this is really important because if a patient is thought to have a seasonal influenza, the containment and prevention measures that we would take to try and contain the transmission of the virus may not have been met. It's also important because that patient may not receive the correct therapeutics that that patient would need. We also found that 3 H5 subtyping assays were found to have a decreased sensitivity at the point of limit of detection when compared to strains that the assay was previously validated with. So in conclusion, we found that 16 out of 18 frontline influenza diagnostic tests screened had mismatches which were at risk, high risk, to have an impact to those tests. A further 4 influenza subtyping tests were computationally screened and found to be at risk due to the presence of mutations within the prime and probe regions. Laboratory evaluation of 13 tests identified that 8 out of 13 were found to have a decrease in sensitivity of 1 to 3 logs at the limit of detection, which would increase the false negative reporting. And laboratory evaluations of subtyping assays found that 1 led to the misdiagnosis of H5N1, and 3 subtyping assays were found to have a decrease in sensitivity. So what does all this mean? Well, it means that we need vigilance and effective proactive post-market surveillance to ensure that our diagnostic tests remain fit for purpose and maintain performance. And this is the responsibility not only for public health bodies, but for manufacturers, and to ensure that this is done at a frequency that is relevant for the pathogen that is being tested for. So I have many, many people to thank. I won't go through all of these, but there's many team members, both past and present. There's many teams across the organisation that I work with. I'd like to thank the regional laboratories that participated in the wet lab evaluation, as well as the devolved administration laboratories. I'd like to thank the regulators who I work closely with, the MHRA, and the USDA for supplying the strain that we used for this evaluation. We've also got many, many stakeholders that I'd like to thank here.